Hi, everybody. This is Susan Clinton, one of the co-hosts from Tough to Treat. In this episode today, we're going to be talking about a symptom-driven type of issue that turns out that maybe the symptoms aren't actually where they're being expressed, but maybe they're being driven through a different kind of systems approach on a person with SI joint pain and expression of pain around that area. Have a listen, give us your feedback, and as always, thanks for being part of the Tough to Treat team. I hope you enjoy the episode. Hi, everybody. I'm Susan Clinton, and I'm here with my co-host, Erica Mello. Hi, Erica.
Hi, Susan. How are you today?
I'm doing well today. And everybody, we are Tough to Treat. And we are going to dive right in and see how things are going and have a good discussion around this particular client, I hope.
Perfect. Let's do it.
So it was interesting. We were talking earlier before we got on the podcast about tendinosis and tendon changes in people and how sometimes those can really occur at what I like to think of as hormonal transitions for people. Mm-hmm. And so that's just going to kind of set the tone for what this particular person I'm going to talk about. This lady is 53 years old, and she's a female, a white female. Kind of short in stature, not terribly so though, a little bit overweight, but, kind of a healthy person that has most of her life, worked and walked and, raised a couple of kids and, anyway, has suddenly found herself in a situation where as she's transitioning into menopause or perimenopause, where she has suddenly found herself in a situation where she is having an increased issue with stress urinary incontinence. And she kind of had it a little bit off and on throughout the years, but nothing that alarmed her, and didn't realize that it wasn't normal. She just kind of normalized it. Yep. And moved on with her life like many people do. It wasn't very problematic at all. But now it has become a lot more prevalent, and it's happening just about every day. And she's having issues. So she came to me because she had heard about, pelvic floor stuff, and she just thought she needed to get on top of this. And so she came in for an initial, kind of eval consult, the whole thing. And just asking her a lot of questions about her stress urinary incontinence. When does it occur? How often does it occur? What's going on? So many people will give you the story of like, when my bladder's really full, that's if I laugh or jump, that's when it's bad. Otherwise, I'm good. Well, it seems to be much more movement related and less whether her bladder is full or not. Of course, it's always worse when their bladder is full, but she's leaking when her bladder isn't full as well.
Oh, interesting.
So, and her biggest issues are sneezing and coughing, of course. Yep. But she also is having issues when she has to walk for long distances, or walking and carrying for long distances. And if she is also getting up out of a chair and or bending over to pick something up.
So all those movements, interesting. Yeah.
Yeah. Mm-hmm. So, and those are all movements that increase intra-abdominal pressure and, so anyway, I started ticking off bells in my head about, okay, so, what kind of a, what's the driver behind this urinary incontinence? Is this really a pelvic floor weakness or force production problem? Or is this some sort of other problem that the pelvic floor is a piece of and truly may have force production issues, but is doing Kegels or just treating one muscle going to solve this issue?
Yeah, probably. Yeah. Right. Yeah, no, probably not, right?
And that's, it's just the way that I go through things. Exactly. Is like, I just want to, I can give people Kegel exercises, but 9 times out of 10, it doesn't really solve all of their problems. So I always try to start from the very beginning. And it's like, let's look at this from a status standpoint and try to figure out what's going on.
Mhm. Mhm.
She's not really having a lot of trouble with urgency and frequency, although she can say that, if she doesn't pay attention, or if she has, a glass of wine or something, that, she'll have to like hurry and rush to the bathroom when she feels the urge to go. But for the most part, not really a problem. And she sleeps well at nighttime, so she's not getting up 3 or 4 times a night to go to the bathroom. So we don't have any of those issues as well. So I just started asking her some other questions, like what else has been going on? Tell me about the rest of your life and what's happening. And so she said that she had been, she stopped bleeding about 6 months ago. So she definitely is moving into menopause,
Yep.
although she can still have a few cycles before it's all done. She said that she has had some trouble with night sweats, so just menopausal kinds of things that are happening. A lot of problems with dry, itchy skin, and recently had to be placed on blood pressure medication that she, just couldn't figure out why her blood pressure was slowly rising. And the other thing is that she's on bioidenticals for progesterone and estrogen.
When was she put on those?
About 6 months ago.
Okay.
So anyway, so just so we have that kind of little information there. And the other thing is that she mentioned is that she kind of had been going through a really kind of tough time in her life, just with just some transitional changes as far as her kids growing up and leaving, and looking at should they sell their house, should they keep it, what should they do with this. They're just making, she's just kind of at at a time where she's kind of looking ahead to what do we want to do to make ourselves more comfortable and be able to do the things we want to do.
Right.
And in the meantime, she said that she likes to travel, but she hasn't really been traveling very much in the last couple of years. So I asked her just a little bit about that, and it was like, because usually she and her husband take some sort of a trip, 3 times a year, but they haven't over the last 2 years. And she said, well, I'm just having a lot of difficulty walking because of my knee.
Her
Like,
knee. I was
oh,
just
your
going to ask
knee.
you.
Okay.
Other
Tell me
injuries?
about that. Tell me more about your knee. I want to hear a little bit more about that.
That's funny.
So she just said that, 2 years ago she felt like it was kind of an insidious onset. She didn't really hurt herself, although she has history of, knee pain back when she was young, like in her 20s, but no big deal, nothing that stopped her from like living life and moving on. And she said that about 2 years ago, she started having this insidious kind of onset of pain, and not really any swelling, but it just hurt, and certain movements hurt, twisting movements, and if she would stand up on it wrong, or sometimes just stepping down off a curb wrong, would create this kind of what she called slicing pain in her knee, and
Yeah.
it would just kind of like stop her for a bit before she could like kind of shake it out and move on, and then she would kind of be able to walk on. Some days worse than others. Sometimes mornings worse than evenings, but didn't, it kind of was definitely worse in the morning than the evening. Sometimes in the middle of the day, if she sat for a long period of time, it would be bad. So kind of some of the stuff you kind of start thinking about that, she's getting a bit stiffer, but it's only happening in the one knee. It's not happening in both. She doesn't really complain about any stiffness anywhere else except the joints of her fingers are stiff, and a little bit in one shoulder greater than the other. But again, still, she feels like she moves okay with those. She doesn't have any pain lifting or grabbing or pulling, with her arms or anything like that, just some stiffness in her hands.
So,
yeah. And then she, was really talking a little bit about that she finds the hardest thing for her to do with her knee, besides the stuff that she, those transitional things that kind of cause that quote slicing pain, is if she has to stand for long periods of time. She said, if I have to stand for any length of time, it's intolerable. Not only my knee, but everything. I just don't tolerate, quiet standing for greater than about 15, 20 minutes. Yep. So anyway, so now we have kind of that in the background as well. So now we have this, you can kind of see the picture we're painting here, 57-year-old female, stress urinary incontinence, knee pain, some encroaching stiffness, definitely nearing the end of her perimenopausal time, and moving into her new age of menopause, time of big transitional hormones,
Mm-hmm.
and also having a couple of health concerns here with decreasing activity and increasing blood pressure.
Yeah.
So she came to me for stress urinary incontinence, so we need to address that. But as I said, as far as I'm concerned, if I don't help her with the rest of these systems, we're not really going to get the result I think she's looking for.
Right.
So anything you want to add?
Quick
Any
questions.
questions?
Yes. Did she have any therapy for the knee at all anywhere, or did she just let it? Okay. Also, any other past medical history in terms of injuries, falls, or anything like that?
No, not really. Like she said, she just, pretty healthy most of her life. Never really had any surgeries. Maybe tonsillectomy as a kid.
Okay.
But.
Any? Yeah, yeah. So no, and what does she do for a living? Did I miss that, or?
She's a professional that works in an office where she does standing and some teaching, sitting, and computer work and some travel.
Okay, so she can, so she can't, the stress urinary incontinence comes on with walking and carrying, but did you say that when she lifts and standing, she's okay?
No, when she bends over to lift things up, sometimes she'll leak thin as well.
Okay, so it's static lifting, dynamic lifting, walking, and then going from sit to stand.
Right.
Okay, did she have any foot issues, any foot injuries or anything like that ever?
Nope.
Okay. Okay, I think those are all my
Yeah,
questions.
never had
Yep.
any problem that she knew of at any time.
It's interesting though because the standing, I always think about where's the center of mass in standing and how does that
Mm-hmm.
affect the pressure. So
Mm-hmm.
I'll let you you go with that. But that's my first blush. Standing and
Mm-hmm.
walking and sit to stand are all different, but standing is like we never stand on both legs. I mean, I never do. So I always,
Mm-hmm.
I'm always looking at the center of mass and to see if that correlates. So
Mm-hmm.
that's what I would focus on. Anyway, you go ahead, keep going.
Yeah. So anyway, I asked her kind of what she was, really concerned about and what she was really super worried about. Um, because she was kind of alluding to like, well, all of this is just normal aging stuff and we just need to get this urinary incontinence under control.
Mm-hmm.
And I said, well, what if all of this was actually working together? How would
Yeah.
that change your viewpoint on things? What if you know, if we could connect, if we could show that, maybe some of this stuff was like contributing to each other.
Mm-hmm.
Like perhaps maybe the fact that you're holding yourself different because of urinary incontinence could be increasing your knee pain, or your knee pain could be causing you to stand in such a way or move in such a way that your bladder is now being kind of pulled offline. Not your bladder, sorry, pelvic floor, kind of being pulled offline a little bit. And so we talked a little bit about pain and over recruitment and under recruitment and weight shift and some of those types of things. And I said, what you're describing to me are kind of movements that bring this on. And if we've got some issues in the movement system, we should address all of the issues in the movement system and not just the pelvic floor.
Mm-hmm.
And this is always my big cry out there, is that everybody wants to be so pelvic floor centric, and I get it because nobody else is looking at it, but we got to put it back with the system.
Yep.
And it doesn't work in isolation. It absolutely does not. So
Mm-hmm.
so I wanted to paint a picture for her to help her kind of begin to look at it from a different point of view. I didn't want to tell her what she was feeling was wrong. I just wanted to help try to start bridging that gap to create that narrative, so she would understand
Mm-hmm.
that maybe we need to not just look straight at the pelvic floor, but at some of these movements too, and see if
Yeah.
we can't really,
Like connect the dots.
yeah, and get the whole
Yeah.
system working together better. But I told her, I said, until we start moving, I won't know. So let's get going. So, basically when she stood up, you can imagine she stood, she had right knee pain. She stood on her left side. I mean, she really was shifted quite over on the left. And I just asked her where she was feeling pressure under her feet, like under your toes, under your heels, where, side, middle, where. And of course, a lot of pressure under the left lateral border of the foot. The right foot felt like it was on the ground all the way, but not as much as the left foot was. So she definitely felt her weight shifted over there. And if you just looked at her body, you could just see that not only was she side shifted, but she had a concomitant rotation to the right of
Yep.
her thorax.
Mm-hmm.
So, and that makes sense. If you're going to shift that far to the left, you're going to have to do something, to
Totally.
get you kind of like back over, midline somehow, and
Mm-hmm.
then, then kind of then the cross rotation with the head back to the left. So just kind of
Mm-hmm.
seeing that general rotation, derotation, rotation through the trunk, all
Mm-hmm.
the way up from the left leg. And and I just asked her, I said, right here, tell me what's happening. Well, nothing other than, if I stay here long enough, my it's just gonna start hurting everywhere. And I was like, okay. So, but she didn't really have knee pain while she was standing there.
Mm-hmm.
So I just asked her, I said, just, why don't you just try to even yourself out on your feet and just see what happens? Like, see if you can make your feet feel even. So when she did that, she definitely had some knee pain come on. And then, but she was able to get there, but she said, I feel it in my knee. And I said, is that the same familiar pain that you usually have in your knee? And she said, no, that's the pain I always have, like that kind of underlying pain, but it's not that slicing pain.
Mm-hmm.
I said, okay,
Mm-hmm.
I'll go with that.
Yep.
So what happens if we actually lean off and get off of the left leg completely? And that kind of increased her knee pain a little bit more.
Mm-hmm.
And so, yeah, and, so we just kind of like played with that a little bit and started just kind of going back and forth. And I said, well, go back to the left where you don't feel it. And so we just started playing with sway because I like doing that for people when, especially if they're hurting with standing for long periods of time.
Mm-hmm.
What I was trying to do is see if I could start getting her some strategies for
Yep.
being able to have some legitimate movement
Mm-hmm.
so she doesn't feel locked into a standing position just straight over there on the left side.
Qu-
And I said, but just kind of avoid the pain, find the edge, so she just would kind of sway back and forth and, feel like where she could go. We went forward, we went backwards a little bit, just to get her a little bit more comfortable in standing. And we didn't have a ton of time to finish up that day. So it was important for her to like pay attention to her pelvic floor.
Mm-hmm.
But what I offered to her is I said, before we start doing internal exams and doing all of this stuff, let's just use the ultrasound machine and see if we can just figure out what your pelvic floor is doing.
Mm-hmm.
Because that's going to dictate what I send you home with today.
Mm-hmm. Right. Right.
Because I
Right.
already kind of got the sways going. So now we've got something a little bit more dynamic going.
Mm-hmm.
There's just not enough time to throw 10,000 pounds of information at people.
No, especially if you're trying to get their story and their narrative, it's important on the first visit.
Yeah,
And,
you know,
the pelvis was meaningful to her, so you send her
yeah,
home and then you could finish up the next visit.
right. And we
Yeah.
talked a bit about how the feet and the pelvis all work together and how doing some of these sways can activate things differently and the muscles within the pelvic, cavity, the pelvic
Mm-hmm.
floor, the hips. And, I had her put her hands on her hips, on the side of her pelvis on both sides. She could feel muscles turn on and turn off,
Yep.
as she kind of moves. So that's always nice to do, I think, for people. But anyway, I have a real-time ultrasound machine in my clinic. It's not the best one on the market. In fact, it's probably the lowest grade one on the market, but it works to see muscles.
Yep.
And we did a suprapubic visioning or visualization of the pelvic floor, and asked her to do whatever she thought was a lift, and also asked her to take a deep breath in, so
Mm-hmm.
we could see if there was any pelvic floor descent or lowering like it should. And basically what we saw was like not a lot of movement in the levator plate.
Mm-hmm.
So not sure if she was holding it tight or if it was over recruiting or if it just was completely, offline.
Yep.
I don't know. So anyway, we just did some quiet breathing, and then we did some bigger breathing, involving the chest wall as well as the abdomen, and just kind of just getting some breathing going for her. And then we
Mm-hmm.
could see the pelvic floor begin to move. And so she
Mm.
could really see that, oh, when I take that nice, wonderful breath in, it actually goes down.
Yes.
Yes. And so after we did that for a little bit and got that moving, then I asked her if she could like recruit that pelvic floor, give it a lift. And she was able to actually start to lift it up.
Yeah,
So
there you
part of
go.
the problem with her is I think that she had a pelvic, well, I know from demonstrated for what I saw was that she had a anyway, so she has an over-recruiting pelvic floor, which can happen, and that can lead to stress urinary incontinence because the pelvic floor doesn't move. It can't lift, nor can it let go. It can't elongate. It can't, it's just being held tight. It's like an isometric hold.
Yep.
And, that actually can drive that type of incontinence. And oftentimes you'll see that a lot more with urgency, frequency, or pain. But you can also see it during these kinds of things too. And I see that a lot, and it's particularly in some of these patients who are, have some pretty set movement patterns stuck in their system, and the pelvic floor can be caught in that. Here's somebody who's having knee pain. She's standing off to the left all the time because her knee hurts. She has pain in standing, so tell me her pelvic floor isn't going to over-recruit in the face of that.
It's like the podcast that we did with Jackie on the leaking.
Yeah.
Similar, very similar.
Exactly.
Yeah. If anybody missed that, I think it's a podcast. It's a recent podcast. It's a very interesting, very similar presentation.
Right, because she had the foot pain.
She had the foot pain. Yep. Same thing.
So anyway, so she kind of got that. She was excited. She goes, I see. And so I told her, I said, listen, I said, before we start doing all of these exercises and all of this stuff, let's just do the simplest things we can possibly do. What I want you to do is I want you to take time out of your day whenever you can think about it, and just do about 2 minutes of this breathing, quiet breathing. I just had her put one hand on her tummy, one hand on her chest, and I just say, just have your hands move together. So, so that they don't just overinflate their belly, but the chest wall gets moving too, because that really helps the autonomic nervous system. And I said, and then do the sways, as much as you possibly can, and just start paying attention to kind of, where you are and what's happening, and what you can change kind of immediately in the moment.
Yep.
So she left with that, and then I sent her some resources on pelvic floor dysfunction and how it works together with muscles of the hips and the legs and the trunk and all the stuff, and that if we've got one part of it that is not working as efficiently as it could, that could drive the rest of the system to have to compensate for that. And for a long time we can compensate just fine, but then at some point we can't anymore. And who knows what it was?
Yep.
Who knows? Was it the stress in her life? Was it the time of hormonal transition? Who knows? Nobody really can. We know that there's a lot of factors that can drive into that.
Yep.
So she left with that. She came back the following week. She was very, very excited, because she felt like for the first time when she sneezed or coughed that it wasn't nearly as bad as it was.
Awesome.
And I forgot to tell you, she was wearing pads all the time because she didn't know when it was going to come on. And
yes, yeah.
So, and she could tell the difference right away. She goes, it's not gone, but it's not like it was. And she goes, so I don't know what did that. And I said, well, sometimes when we just get some different movements in, it starts to get the performance of other muscles to change.
Right.
Let's just kind of go with that and check some more things out. So then she was really interested about, what she could do to really, she was on board now because there was a change.
Yep.
And she didn't have to work really hard to get the change.
Yep.
You just had to become a little bit more mindful about a couple of movements that I knew were problematic for her to create and start driving some of the change. So, but that actually brought her into, she goes, well, then what can we do about my knee? I said, well,
typical.
But I said, let's just take a look at everything, shall we? So we had a little bit more time the next time because, the buy-in was there, and it was like, so we did a typical PT eval of the knee. It's lacking some extension. It doesn't flex all the way, just a little bit of a typical kind of stiff held pattern. One of the biggest things was because of the lack of extension, she wasn't getting the external rotation of the tibia.
Yeah.
And so she was lacking some rotation through that joint that we know it has to be there, particularly, for straightening out all the way.
Yeah.
So that was what was driving the change in walking, was she wasn't really getting that rotation through the knee that she needed. And so it was making her stay on that left side even more because she had to do something to get her weight over the right leg and onto the left leg. And so the brain, her brain just like pulled her over there and said, just stay over here. It's easier,
Yeah, because
so.
yeah,
Mhm.
exactly. Because at some point, the right leg, just the right knee or the right lower extremity can't adapt because you've been on that left side for so long,
Right.
and the brain is like, well, I can't get myself over, and it goes through changes, and it loses its adaptability for
Hmm.
the person to change their center of mass with ease, and that's fairly common, I think. So
And so here we have a situation where we've got some pain in a joint that's driving some huge load transfer problems.
yeah.
And it's still a little difficult for her to shift over onto the right all the way. So we just kept, I would have normally taken people into stand on one leg, stand on the right leg, stand on the left leg, but that hurt her. So there wasn't any point in driving pain at this point.
Yeah.
So she was good with the sway. So I said, we need to start. How do you feel about starting to like get this knee loaded in some different positions? Especially sit to stand, because that was a big one, right? And I knew you, I could see you smiling because Erica likes that one, and I said, so let's just do it. Just do your normal sit to stand. And you can imagine she shifts all the way to the left to
Right.
come up.
Yeah.
And I just kind of went in like your trick, which I love. And I just kind of held her head and I said, okay, let's do it now. And all I did was just cue her towards midline
Yep.
as she came up. And actually, here's the crazy thing, which I love. This is what I love about playing with the motor system so much. It actually didn't feel as bad on her knee as she thought it would.
Yeah.
And it
Interesting.
actually kind of felt better
Yeah.
because she
Yeah. I would
wasn't torquing
imagine.
her knee from, trying to go sit to stand from a flexed position over to the,
Exactly. Exactly. Talk
So,
about, strain.
mhm. Anyway, and I said, some of the things that you do when you go to sit to stand that I'm noticing is that you're shifting way over, you're holding your breath. That could be some pieces that are driving some of the incontinence as well.
Yep. Yeah, it's like a twist in
So,
the system.
yep. So we worked on just kind of, getting her to feel how to make that a little bit better, feel okay with her knee, just drive some more confidence into the fact that that leg can hold her up on the right side a little bit better, that she can push through it. And we
Mm-hmm.
did the sit to stand from various positions, from like a taller stool to a, shorter chair,
Mm-hmm.
to wherever she was comfortable with her knee being bent,
Yep.
basically is what we did.
Yep.
And I just basically added in breath and voice with it because I didn't want her to hold her breath. So I made her talk and, and I made her breathe. I just, asked for that to come in and to see if we had any buckle points in there. And generally her buckle point when she was talking was like at the beginning of sit to stand, that initiating the movement.
Yep. Yep.
So her homework was to go home and use her voice with a lot of these motions. We did a lot with sit to stand. I said, but you can do this walking up and down the stairs.
Mm-hmm.
You can do it when you bend over to lift something. You can do it in and out of the car.
Yep. Yep.
Just even if you want to just quietly hum to yourself, so if you're out, where people would hear, or whatever. I said just give it a try and see how it goes. But the big things for you is to continue the sways, the breathing. Things are starting to get better, and let's start working on the sit to stand, because that's going to be range of motion, loading, and function.
Yep.
And
Yep.
those were three things that she was not doing. So if you want to talk about impairments, here's your range of motion change,
Mm-hmm.
and here's your loading, for strength and control.
Right.
And function is function. She needs to get up and down from all kinds of different chairs, airplanes, everywhere, all the time. So
Totally.
yeah.
And if you can't straighten your knee out or you can't fully flex, and you're going from sit to stand, and you're shifting your center of mass to the left, you can treat that knee all you want. And this person keeps doing the same strategy over and over again, that knee's never going to get better. And that's what I think the whole thrust is, that you just need to watch the move, and
Mm-hmm.
and at some point, it's not like the knee issue happened 2 days ago. It was a long-standing issue.
Right. So the third time she came in, things were still getting better. She still was leaking some, but nothing like she was before. And I told her, I said, okay, let's finish up working with the knee a little bit more, and then we can add a little bit more into force production work for the pelvic floor.
Mm-hmm.
But I still feel like that we need to get, some of, I feel like that you're making improvement in how you're moving around. How do you feel about that? And she said, I feel pretty good about it, but I'm noticing some spot tenderness on the front of my knee now that I didn't notice before. And I said, well, how is that different than what you were feeling before? And she said, well, what I was feeling before was more like inside the knee.
Yeah.
And she goes, this is just like right. And, of course, you can imagine where she pointed was right at the patellar
Patella
tendon.
tendon. Yep.
And so here we go.
Tendon.
57 years old.
Yes.
Hormonal transitions. And,
Yes.
now this is starting to kind of look a bit like a tendinosis.
Yes. Yes.
And so, so we talked about it a little bit, and I said, well, what's really being unmasked here is probably the original driver of your knee pain.
Yes. Yes.
And I said,
Pain
and
generator.
I
Yeah.
said, and it, as your knee gets a little bit straighter, that it's just, and the way that you're standing kind of makes that have to work all the time. And it's just,
Yep.
we talked a little bit. I don't like to use the generative with people, but I said, what you have is you just have some changes in the tendon. And we're not real sure if the tendon changes back, but we do know that if we do the right kind of movement exercises, we can actually make this a lot better.
Yep.
So, there wasn't any reason to go into, what happens is that, the good fibers come in and wall off the bad fibers and take over, all that.
And
I just don't think we know yet.
Right. And she's only been on hormone replacement 6 months, right?
Yeah.
You said, yeah.
Right.
Okay. Yeah.
So, anyway, so we started in it. So some of the things we talked about was, how can we start loading? And so sit to stand was perfect.
Mm-hmm.
And I said, so tell me which sit to stands bother it, and it was the deeper ones.
Yep.
I said, okay, so let's stick with the ones that aren't quite so deep.
Yep.
And let's just start, loading those a little bit more. Then she was, so she was on board. We started doing, she's got to do stairs, she's got to walk, curbs, everything. And I said, let's just start with some, lower, like a lower stair, like, a couple of inches, and do some step up, step down, step forward,
Mm-hmm.
step back, step sideways. I like to step up sideways because it gets the pelvis involved a little bit more too from the lateral end.
Yes.
And we just started, doing different things. You can put some weight in your hands as you do it, so we started just kind of writing out a loading progression and, thing. And I said, here's the thing is that it's probably going to hurt when you do this a little bit, but as you keep going, it should not hurt as much. So if it's not backing off, then we have to back down.
Yes.
I said, because when we start to stress this tendon, it's going to be a bit painful.
Right.
But that doesn't equal harm.
Right.
It just means that we're actually stressing what needs to be stressed. However, as you do more reps, it actually should be feeling better.
Yes.
So
yes,
we kept it at that.
Yep.
And so I wanted her to have that kind of like, here's your homework, here's what you do,
mm-hmm.
Here's how you keep going. And of course we kept going with the breath and the voice to it too, so I could keep driving that internal system to not start holding breath and doing some of those things that could drive a little bit more pressure down onto the pelvic floor.
Mm-hmm.
So, and, we were able to kind of progress to, over the next couple of visits, we were able to progress to some lunging. I had her work on some lunging, holding on to some TheraBand at home so that she could ease down into the lunge better. You
mean TheraBand out in front, like a bilateral arm lift? Yep.
Or right up underneath it too.
Yeah.
We started working on squats with the TheraBand holding on, so that she could begin to ease herself down into squatting and to move. You can hold on to doorknobs and to kitchen sinks also works well for like sit back squats and things like that. Just trying to get some more movement into her life as far as really helping her get the confidence of her knee back. And then I wanted to work on getting her knee extension a little bit better. So I had her, you can do this with those big bands that can hang from like a pull-up bar, or you can tie, really heavy TheraBand around, the top of a door or on a hook. And I basically had her bend her knee up and put it into the loop of TheraBand. And the exercise was to step down with that foot. So she was getting the resistance on the step down.
Got it.
But on the back up, the TheraBand was assisting her up into flexion.
Got it. That's
so we played around and did some of those things. And of course, just any of the hip and, motor control stuff with, monster walks and lateral glides and any of those kinds of things. And so over the next 2 to 3 weeks, she was progressively getting better. And her incontinence was slowly getting better too, but it was time to kind of go ahead. Now we need to maybe address and see what's actually happening with her pelvic floor. So we did an internal exam. She had fairly good movement. It could have been a lot better. So she was beginning to recruit, but she wasn't recruiting as well as she could. So we added some breath and voice to that, and then added that feeling of increasing the recruitment that she learned laying down, immediately got her up and got her going. So now when you do your sit to stand, as your breath comes on, remember that's going to help you automate and pull that pelvic floor up. So she started to intentionally pull that piece in with a lot of those exercises and things like that. So she didn't have to think about holding her pelvic floor high and tight the whole time, but just as, as she began to use her exhale, that pelvic floor would come up and in.
Yes. Yeah. Yeah. I think it's fascinating because the with the breath work, because I'll just make one comment but what, like when her center of mass is way over to the left, I always look at, is it the thorax, where is it coming? Is the head, the thorax, the pelvis? And what you were doing with the breath work is what I do. Like if I see someone has poor thoracic control, I'll start with breath, and I'll have them do in supine, hook line, lower trunk rotation with either lateral costal breath, apical breath, diaphragmatic breath. And you were doing that, and sometimes with that type of intrathoracic pressure or loss of control in the thorax, you can see all these center of mass shifts. And that's, at the end of the day, with the reason why I asked about the lunges with the TheraBand, because I give that one a lot with the TheraBand and lunging, because that helps them control their thorax,
Yeah.
And that's
fantastic. Remember, she had that kind of weird twist thing going on.
Yes.
But I didn't have time to go through all of the progression, but that we went to single leg stance, and then we did some rotational stuff with the thorax on single leg stance before we moved into step ups and all of those kinds of things. So you can do those combinations of stuff. She's doing them anyway, so it wasn't like it was off limits to do. I was just trying in the beginning to help her figure out how to calm her knee down a little bit and not be afraid of using that leg, and then begin to build things back up again around it. And bring that pelvic floor and the rest of her system in, so that she was working all together. So where we ended up, I saw her about 6 months ago. She came in for a recheck because she was having, I don't know, just a little minor back pain, and she just wanted to be sure it was fine. But basically where she she goes on the elliptical. She rides a stationary bike. Because I got her on that too, as we kind of, do that knee movement, just let's get some stuff going. I got her into the understanding of that, because she would use things like bone on bone and arthritis, and it was like,
not helpful.
That's, what's happening. You have normal aging and you have abnormal aging, and abnormal aging is giving in and not moving. And, for many reasons. And I said, so we want you to get back to where you should be able to age without all of this pain and stuff.
Grace. Yep.
So on the final note, just to throw it out there for people to keep this in mind, because I'm not going to go through it all here on this podcast, but I gave her some resources on her hormones and blood pressure. And one of the biggest drivers in perimenopause into menopause for blood pressure is progesterone. And it's unfortunate because progesterone is also the thing that makes you feel better. It takes away the night sweats, those kinds of things. But even the bioidenticals can be a driver. And I gave her that information because I thought, she's maybe something she has to look at. And she did tell me when I saw her 6 months ago that she made the conscious decision to drop the progesterone off and not use it. And she's had her blood pressure actually started to stabilize after that. She's still on a very low dose of blood pressure medication and hoping to get off of that at some point. But she was continuing to have this kind of quirky rising, falling blood pressure. And so I don't know if it was because she changed her progesterone. Nobody really knows. But we do know that sometimes in some individuals, so if you're treating women in their perimenopausal to menopausal years, that sometimes the hormonal replacement therapy, depending upon what it is, can actually drive blood pressure up.
Interesting.
And a lot of people are not paying attention to that. They just may not be thinking that it's that. So I just put that out there. Just people can read more about it and understand it a little bit more. For her, she just decided that it just wasn't worth, she could put up with a few night sweats and not have the progesterone and would be just fine. Oftentimes people will use hormonal replacement therapy, whether it's synthetic or bioidentical, as a transition, to get through the transition, and then
Correct.
oftentimes feel very comfortable dropping it off at
Dropping
that
it
point.
off. Correct.
So, but you still need to like eat well. You still need to be, eat good anti-inflammatory foods. There's a lot of things you can do with seeds, sesame seeds and sunflower seeds ground up can be like a very natural hormone replacement for progesterone. So you can throw that in.
Yep.
So there's other things that she could do. I just gave her some more resources and told her if she was interested, I could send her over to, a nutritionist and see. And I just mentioned to her too that I said at some point you probably should have a full thyroid panel done.
Yes.
Just be sure there's nothing else lurking and going on at this time of transition for you.
Yeah, 100% agree.
Yep. Yeah. So anyway, I just wanted to throw that out there because we did talk about it in the beginning. And that I can give people some information about stuff, but I also have them follow up with their physicians. If they're not getting anywhere with their physicians, I help them find a physician that will look at things a little bit more in depth with them. But I think as we move in and work with people in menopause, we need to think about things like loading and bone health.
Totally.
We need to think about things like tendons and healthy tendons, and we need to certainly think, how do we keep people moving? And we need to think about things like, hormones and changes in food and, and all of these other things that can drive really much better health for people, as they move into this next stage.
Yeah, no, I 100% agree. Awesome.
Awesome.
Cool.
Okay.
Thanks, everybody. Enjoy.
Erica, did you want to say something about the mastermind?
Oh, yes. At CSM in February in Denver next year, we are hosting a one-day clinical mastermind on the Wednesday. So CSM is Thursday to Saturday. It would be the Wednesday before. It's going to be, our two of us together. Bring us your patients, bring us your questions. We're getting the details sorted out. If you are interested, please email me, Erica at ericamello.com or Susan at embody-pt.com, correct?
Yep.
There you go. It'll be absolutely fabulous if everybody could join us. Just register your interest now before it sells out.
Okay. Thanks, everyone. Have a great day.
Bye.
Bye.